So welcome everybody to our 11:30 panel. My name is Debbie Schlossberg, and I'm the Chief Care Services Officer at ALS United Greater New York. And for those of you who may not know, even though we do think that New York is great, we're called Greater New York because we encompass not only the 5 boroughs of New York City, but all of Long Island, the lower Hudson Valley, and northern and central New Jersey. I am going to be introducing our panelists today, 3 of whom are here with us, and 2 are going to be joining us virtually on the very, very pivotal and important topic of home care. So first, we're going to get started with Lara. I'm going to introduce her, and I'll introduce everybody in turn. They'll speak, and then just as, you know, same format from our previous presentations, then we'll open up the floor to Q&A. So Lara is going to be talking to us from a grassroots VA angle. We're going to be sort of addressing the topic of home care from several different angles. Lara is a survivor to her late husband, United States Air Force veteran Tom Garey, who was diagnosed with ALS in 2016 and passed away July 15, 2022. During Tom's illness, Lara became his full-time caregiver, and her advocacy led her to apply and be chosen by the Elizabeth Dole Foundation as a fellow representing Texas in both 2019 and in 2020. And she began volunteering with the I Am ALS Veterans Team, which I'm sure she'll tell us about, to further her advocacy efforts to support veterans with ALS. As a survivor, Ms. Garey is continuing her awareness and advocacy efforts to help families on the beyond side of ALS. Next joining us is Linda Gregoire. Hello, Linda. She's a caregiver and co-founder, together with her husband, John, of Hope JG Fights ALS. She has been John's caregiver for almost 17 years, and they started their foundation in 2014. The foundation has 3 goals. The first is a residence, which would be a long-term goal where people with ALS could live. Helping Hands, which helps pals with practical needs immediately, would be also a part of that. And finally, John loves to research and to find new technology that will make life easier. They've also worked to make changes in a caregiver law to help families in Maine live a more fulfilling life. And on the other side of that conversation, we have another guest, and that's Patrick Corey, who's a state legislator from Maine. Mr. Corey represents Maine House District 25, comprising part of the town of Windham, Maine. Anybody here from Maine? Does that mean anything? Okay, Windham, Maine. And during his 4th term from 20 to 22, Corey served on the Committee on Appropriations and Financial Affairs and the Committee on Veterans and Legal Affairs. Moving down the table is Lara. Hi, Lara. And Laura's going to be talking from more of a government relations, government affairs perspective, because Lara serves as Bayada Hearts for Home Care Deputy Executive Director with over a decade of experience in home care and government relations. Throughout her career, Lara has played a central role in the Government Affairs Office's expansion at Bayada, and that has included opening new markets, creating and managing key governmental relations programs, and expanding the team's role in business operations. In 2021, Lara was elected to the Pennsylvania Home Care Association Board of Directors and currently serves as board president-elect. And finally, I'm not going to say last but not least, because my friend has been telling me all day, well, then who's least if it's always last but not least? Last and least, I'm sure that's not true, is David Lipschutz, who is the who is an associate director and attorney at the Center for Medicare Advocacy. So we're also going to be looking at this from the lens of Medicare. He joined the Center for Medicare Advocacy in June 2010, and he engages in public policy issues surrounding Medicare and related coverage as they impact Medicare beneficiaries. He came to the center after 5 years as a staff attorney at California Health Advocates, a nonprofit organization that provides advocacy and education for California Medicare beneficiaries. And pretty much everything I just said is written down in your programs, but it never hurts to reinforce. Okay, so Lara, we're going to start with you and take it away.
Well, I appreciate everyone being here, and thank you for letting me talk to you a little bit about the veteran and ALS connection. Specifically, I'm going to talk about some legislation that is currently in the House right now that will allow veterans to receive skilled home care. But before I get started with that, I just kind of wanted to throw it out there. Do we have any veterans in our group? We don't, but I do see we have some caregivers or former caregivers of veterans. Can you raise your hands? Ashley? Okay. So if you saw the hands of people that took care of veterans, they represent 1% of the US population. Veterans are diagnosed with ALS at a higher rate than those that never served. So when you start to think about that, 1% of our US population actually serves in the military, and they also have the highest rate of diagnosis of ALS. It kind of brings it home. I actually have a picture. I had a slideshow. There's the picture right there. 2 of those 3 airmen have not only been diagnosed with ALS, but they have passed from ALS. The airman on the far left, the really handsome one, that's my late husband, Tom Garey. He was diagnosed in 2016. He lived 6 years with the disease. 3 of his last years, he was trached and vented, and I cared for him in our home. The gentleman on the right is Eddie Ritchie. We called him Richie. This was taken in 1990, by the way, in South Korea. Richie was diagnosed a year after my husband, and he passed a year after my husband, so he passed last year. Richie was stationed with us on the island of Guam, and my husband and him served in different deployments together. So this one picture really brings it home to me on the fact that ALS is more prevalent in the veteran community. So when I was fighting for my husband, when he was diagnosed with ALS, and we learned that we would be having to, go through the VA, I thought to myself, surely it can't be that bad. I've heard things on the news about the VA, but it can't be that bad. But it really was. While we like to think that veterans have access to all this great care, that's in theory. Sometimes you have to fight really, really hard to get the access. And that's because the VA is a big government institution, right? And so it depends on where you're located, how robust your VA is, how knowledgeable your clinicians are. And so when you're starting to ask for things, you get a no automatically. And you have to learn how to advocate, which, we talked about that in that first panel discussion, using your voice, learn to be an advocate. I don't set hair on fire, but I am the squeaky wheel. And so that's how I managed to fight for my husband. And we fought for a lot of things. We fought for his non-invasive ventilator. He needed it in November of 2016, but the VA couldn't get it to him until the end of January 2017. We fought for surgery to get his PEG. We fought for the formula that he was going to use. We fought for the bed that he needed. We fought for everything. But the biggest fight I had was for skilled care, because in early 2019, my husband went into respiratory failure due to his ALS. He was hospitalized with pneumonia. He was told, you're either going to get the trach or you're going to go home on hospice. He chose the trach. And probably about 6 weeks later, we came home. I came home. I'm not a nurse. I came home having to learn how to handle a trach and a vent and a PEG and a paralyzed husband and all these things. And so having to fight the VA just didn't seem like I had it in me anymore. But I'm a passionate person. And so I used all that anger and all that passion for my husband, and I fought the VA. And so I started asking for skilled care because I had learned that skilled care was being provided by the VA on the East Coast. Well, if they could do it on the East Coast, they can surely do it in Central Texas. They can't. At least that's what the VA told us. So I had to learn to elevate my voice from local VA to what's called a VISN, which is like the mothership of VAs. It's Veteran Integrated Service Network, up to National VA here in Washington, D.C. That fight took a year and a half. I was told no so many times. I'm sure that there is a picture of me in the basement of the Central Texas VA that they practice their darts on. But that's what it was. When we love our person with ALS, what do? We fight really hard. A year and a half after I started fighting, we did get skilled care in the home. We were the exception and not the rule. But I will say, in Central Texas, the Central Texas VA now provides skilled care to our ALS veterans 24/7. They get it. Not all veterans are getting that. That is why the Elizabeth Dole Home Care Act is so important. It's actually just a passion of mine. They actually introduced this bill 2 years ago. It is still in the House. In November of last year, that bill was wrapped up into an omnibus bill. And now that omnibus large package contains 19 to 20, I think it was last count, different individual veteran related pieces of legislation. The Elizabeth Dole Act is what it's going to do, is it is going to remove the barrier to home health care. There's a lot of components to it, but the one that we're going to focus on because of this panel is the removal of what's called the 65% cap on care. What that means is the VA will say, yes, we will provide this service if you can get them to get the yes, but they're going to provide the service up to 65% of the cost of care to put that veteran in an institution, whether that's a CLC or an LTAC. My husband did not want to go into an institution, and I promised him he would never do that. I promised him I would do whatever it takes to keep him home, just like many of us want to do. And so that is what the Elizabeth Dole Home Care Act does. It removes the barrier. It takes it from a 65% cap on care for non-institutional care up to 100%. So the VA, in theory, would not be able to say, I'm sorry, it costs too much to care for your veteran in the home. We're just going to go ahead and place them in an LTAC if they're vent and trach dependent. So what does that mean for all of us? Why do we worry about veteran legislation if we're not veterans or you're not in the veteran community? Well, I can tell you we already benefit, every civilian benefits from the VA because the VA is a clearinghouse for clinicians, nurses, OTs, PTs, nutritionists, anybody that you're going to see in your multidisciplinary clinic has done work time at a VA. They've done clinical rotations at a VA, or they have served as a clinician in the VA. We have care services and standards of care that started in the military that now is in the civilian population, like our care for spinal cord injury veterans, our care for amputations. The VA is innovative when it comes to prosthetic development. We do triage and emergency care because of what we've learned in the military. So anything that happens in the military does make its way to the civilian population, which is why we all need to be, on board with the Elizabeth Dole Home Care Act, because at some point, maybe this is something we'll see in the civilian world, which I bet we can all agree, having skilled home care would be so beneficial to all of us. It was for me. Having that in my home allowed me to be my husband's wife, and it allowed me to just enjoy what time I had left with him. Because keep in mind, I was a full-time caregiver, and fighting the VA took a lot of energy and just resources that I thought I didn't have that much of it left to fight. So what this does is this allows our families to be families, and it allows the skilled people to come in and care for our veterans. And so I hope that you all kind of do what the panel said earlier today. Reach out to your elected official. Tell them that this is an important piece of legislation, because if they don't hear from you, they don't believe that it's even important. So be the squeaky wheel, light the hair on fire, let it smolder, however you want to do it. I just ask that you reach out to your elected official, and let's just see this bill pass. And I appreciate your time. Thank you.
Thank you, Lara. And next we are going to go to Linda, I believe.
Hi.
I think they want you to tell them
Oh,
about you.
Yeah, okay. Sorry. I've been caring for my husband since 2007. He was diagnosed in December of 2007. And I made a promise, as I heard you say earlier, that we would keep him home. And it didn't matter if he was on a ventilator, whatever came, we were going to keep him home. And in January of 23, January 6th of 23, he got a tracheostomy, and I've been caring for him at home. I do have some support, probably anywheres from 4 to 5 or 6 hours a day, Monday, Friday. My son, Tuesday, Thursday, we have a very good friend, and on Wednesdays, I have a nurse for 4 hours. That's my one day I can leave the house because she's skilled. She was a recovery room nurse, so she's good with the ventilator. Otherwise, it's just me. And like you said, when I had very little knowledge about how to run a ventilator, and he got dropped off by the ambulance, and we immediately had trouble with the ventilator. And I remembered what they said, bag him. I bagged him and rebooted the ventilator, and that was it. We've just been doing it ourselves since. But I was told early on, my husband's under a waiver program. Instead of being in a nursing home, he's home. He's on a long-term care waiver program. And I could bring anybody in the house at any skill level, as long as they pass the background check, and they could take care of him. But me, I was excluded, and I couldn't understand it. So the social worker immediately said, my suggestion is you get divorced on paper, and then you can get paid. And there's just no way I was going to do that. And, to me, I took my vows very seriously, and it wasn't like, except if you get ALS, then I'll divorce you so we can work around the system. I wasn't going to do it. I just didn't understand why they couldn't change. They said it was only on paper, and I didn't understand why they couldn't just change the paperwork to include me as one of the caregivers that got paid, because I do, it's 24/7. So, Patrick, my representative, I started speaking to him about it, and that's when we started pursuing this at the state level. But I think it's, some spouses don't want to be in the home. I find that this is the way to have that extra time and closeness with my husband. And even though my caregivers all know how to bathe them and everything, I choose to do that because that's how we stay connected. I'm trying to think here. So, and ALS is difficult, I think, in a way that my husband, right out of the gate, was nonverbal, but my son and I could understand him, just certain eye movements and gestures. And I knew as I brought people in, and it's hard because you bring somebody in, you train them, and then they disappear, or they aren't consistent, and you need consistency, and you need them to stick with you. I just felt it was easier for myself to be the main caregiver. So, it is hard to find people. There's gaps. So to have the spouse as the main caregiver and to be able to be paid is beneficial. I think it's beneficial to the families. So I'm sure I'm missing something. What am I missing, Patrick?
I don't know. Do they want me to talk next? Do you want me to talk?
Yes, please.
Okay, great. So my name's Patrick Corey. I used to be in the state legislature. I was in for 8 years, and we have term limits in Maine. So I'm sitting out my 2 years. Now I'm running again. We'll see how that goes. I don't know how it's going to work out, but I don't know if I want to be back there or not. So way back at the beginning, I was out knocking doors, and I met Linda, and Linda told me about these issues. And one thing that I have to say is both Linda and John are kind of amazing advocates for themselves, and then others with ALS, which is really amazing. John, for a lot of my legislative career, could sort of pound out emails with one finger on an iPad and send them, and absolutely brilliant emails. So we tried a bill to take care of this, or at least to get our waiver amended in the state of Maine in the second term that I was in the legislature. So I'm guessing probably back in like 2016 or 2017. So it took another term to do that. It had basically made it through in the first term, and then it died in the appropriations process when we were trying to get it funded. And we really weren't getting a lot of kind of help from the governor's office at that point, to do that. So we created a bill in the following legislature in 2019, and we basically, it was called a resolve directing the Department of Health and Human Services to allow spouses to provide home and community-based services to eligible Maine care members. So that ended up becoming law on January 28th, 2019. So basically what it was a resolve. It was, a directive that required DHHS to submit, or that's the Maine's Department of Health and Human Services, to submit a request to Medicare and Medicaid services to amend our Section 1915C waiver, or our 1915C waiver, to allow spouses to be employed as personal support specialists. And then once approved, DHHS would need to amend its rules in Maine. So I mean, I think that the highlights of this bill really were that, from the start, I got a really good bipartisan group of respected legislators to sign the bill. Like some of the, most important and respected and well-known legislators in the state of Maine signed it. We worked with a lot of organizations. We had a wide array of organizations, from liberal to conservative organizations, that came out and spoke in support of our bill. So we had everything from like the ACLU and AARP to a group called the Maine Heritage Policy Center, which is a conservative organization, to the Alzheimer's Association and Disability Rights Maine and Maine Long-Term Care Ombudsman. It was really kind of amazing walking into that hearing. Probably even more amazing was John actually coming to the hearing, and Linda getting him up to Augusta and everything. I have a funny story about that. They limited John to 3 minutes of talking, and I guess he felt like his speech was longer than 3 minutes. So Linda had wheeled him out in the hallway, and I'm like, what are you guys doing? And they're like, we're amending his speech. I'm like with the iPad and the one finger, do you know what I mean? So that it could be read. I'm like, no. I'm like, they're not going to cut you off. It would look terrible if they did. So it was amazing to see all of these different groups, and it was just group after group after group got up and did it. So I think that some of the big benefits of this bill were that it, helped to keep families together in Maine. In Maine, there's not a lot of sort of care facilities. So, and Maine's also a very big state. So if you're living kind of up in the middle of nowhere, if you did put a relative in a care facility in Maine, you might be driving 2 or 3 hours to see that person, which is, heartbreaking, I think, for couples and families and everything. What the bill did was, because that there was a lot of gaps in service, like, there's not enough paid caregivers up here, that John would qualify for a number of hours per week, and those hours weren't being met because there wasn't enough people. And then Linda obviously had to fill those hours because John couldn't be left alone. So, she was being kind of unpaid to fulfill those hours, which also meant that Linda couldn't have a job or a consistent job. So I think it was really important to give, Linda the ability to do that again. And then another sort of benefit of this is that the bill kind of forced spouses to get trained as PSSs. So, at least, they had some training then that maybe they hadn't had before and being able to take care of people. So this isn't only ALS, this is people that, anyone that would be like, nursing home eligible,
Right.
I guess, to be cared for. So there were some hurdles in this bill. So there were certain assumptions, and some of these assumptions were being put out there by care agencies because they were probably scared of losing some business. But, they were saying things like, that family caregivers wouldn't provide an adequate level of care, or that they would somehow take the money and not provide the care, or they wouldn't get the necessary training, or that they wouldn't comply with electronic visit mandates without being employed by an agency. So one thing that was a huge stumbling block with this bill was that they were trying to say we were going to need something called a fiscal intermediary, which added to the fiscal note of the bill, which would have been somebody, I guess, to watch the caregiver and make sure that they were doing their job. But these caregivers are employed through agencies, anyway, so there was already going to be a fiscal intermediary. So it made the bill much more expensive, which kind of put it in a difficult spot. But we were eventually able to convince something called the office of, anyways, the financial office that creates the fiscal notes. We're able to say basically that
Office of Family Independence.
no, it was something, no, OFPR, but basically it was that all that was happening was, instead of somebody else being employed and then a family member was going to be employed, so it shouldn't have added any additional cost to the care. So basically, like, once we're able to get that piece removed, it reduced the cost of the bill by $22,000 in the first year and $34,000 in the second year. So it made it so that my caucus was willing to devote a certain amount of its money to this to get it passed, and we got it passed, and Linda gets paid to take care of her husband now.
Anybody who's on the waiver program, who's the spouse, or it also affects parents of minor children. We were considered natural caregivers. In other words, we're just going to do it because we're here, and they didn't understand the impact, like, of saying, well, now that my husband's on disability, I've got to go out and get a job, but I don't know who to leave him with because they're not trained. And caring for somebody with ALS is different than caring for somebody who's having some ambulatory problems, like, just using a walker to get around the house. You need to really know what you're doing. And also, knowing that time is limited, I didn't want to leave him with somebody that didn't know him. I wanted to be the one there. I wanted that extra time. And I just couldn't understand. We weren't asking for more hours. We weren't asking to change the pay structure, asked to get paid more. We're just asking the paperwork be changed, instead of a stranger taking care of him, to pay me. And that's where Patrick and Bill Diamond really worked, with the people they knew in these agencies. And it was, each vote was unanimous, wasn't it?
Yeah, it was unanimous.
When it was brought to the committee, it was voted unanimously, but it was struck down in appropriations. But once we could prove to them, actually keeping somebody home lowered the cost of care than putting them in a facility. And in Maine, they won't take somebody with ALS. Even if it's just a feeding tube, never mind a ventilator, they won't take somebody with ALS because the workload, it adds to the workload so much. So for somebody with ALS, if the spouse has to go out of the house to work and they have to go into a facility, they have to leave the state. The nearest facility I can think of is in Massachusetts, Chelsea house in Chelsea, Massachusetts. Barry Berman runs it. And, or we had a patient that our foundation helped take care of, ramps and stuff. And as she progressed, she was having trouble getting caregivers in on a regular basis. She'd text me and say, they just didn't show up. And she'd be home alone. And she was, in bed, no help. And she finally chose to go into hospice. And to me, it's a terrible thing to have to make a decision to live or die just because you can't get the care you need.
Keep in mind too, and we'll let the next panelist go right after this, but this did affect a lot more people than people on ALS that had ALS. It was for people that were nursing home eligible. So if somebody had a traumatic brain injury or a stroke or anything else, they were Alzheimer's, coping with a lot of these same issues. So we really opened the gate on families to get paid in the state of Maine.
And lastly, I don't understand, and maybe Patrick won't agree because he did a lot of the background work, but once we got our point across, it was voted on unanimously and it was passed. I do not understand why other states aren't following, because I have a statistic here, just real briefly. 43.5 million unpaid caregivers in the United States, saving $600 billion. And these people are doing it at the sacrifice of possibly losing their homes, going without, like I was not able to get quarters toward my Social Security, which puts me at a disadvantage once John's passed. And, we owe it to people who are taking care of and keeping people out of facilities, is my thought.
Cool. Thank you.
Thank you.
Thank you. Linda, your last point about being unable to earn work credits while you're doing what should be such highly valued work, it just speaks volumes to the way caregiving is undervalued in our society. So thank you again. And now, Laura, we turn to you.
All right. Well, good afternoon, everyone. My name is Lara Ness, and I'm the Deputy Executive Director of Beata Hearts for Home Care, which might sound somewhat familiar, but also not at the same time. So we are a new advocacy organization dedicated to increasing access to home care services. And we primarily do that in through our legislative and advocacy work in state governments and in Washington, D.C. So to give you a little bit about a history about us, because as a group, we've operated for much longer than our launch in 2023. We actually grew out of Beata Home Health Care, which many of you may or may not know, as a provider of home care services and home health services kind of throughout the United States. And they're in, I think, 7 countries now too. And we were their government affairs team. And we've noticed through our work over the last, I'd say, 15 years, that in order to really move the needle in increasing access to these services, we needed to have more than just Beata and Beata employees at the table and talking about this. We needed to create a movement, and we needed to get others involved. So with that, and we kind of started to talk more about this and try to engage some of our competitors and some partners to get things across the finish line. We found that it didn't work super well because it was so associated with the entity and the company Beata, despite the fact that what we were doing was good for all. We always used to say a rising tide floats all boats. So we decided that we would actually split off from Beata Home Healthcare, the provider itself, and create a separate and still affiliated organization called Beata Hearts for Home Care. So we are an advocacy organization, just like you would see for AARP or, maybe ACLU. So we purely focus in on increasing access to home care and home health services. And primarily we're doing that, as we've noticed and heard so much feedback over the years from folks like yourselves, from people who work in the industry, that the very first thing we have to do in order to be able to do anything else is increase reimbursement rates so we can pay the caregivers adequately, whether it's an aide in the home, a therapist in the home, a nurse in the home. If they can't support their own families, how can we expect them to come to work every day and support ours? You can expand waiver slots, you can change regulation, you can do all of these other things, but if there's not the workforce there to support it, and if they can't be paid adequately, then it doesn't matter, because it's just going to be empty slots waiting to be filled. So that is what we're tackling first and foremost. We're kind of very focused on that, as that's also what we've learned over the years, that if you have too many priorities in too many places, nothing often gets done. So, each year we look in our various states that we're operating in, and we kind of assess what are the 2 or 3 things that we think we can get done that year. And then, we put together a plan and a strategy to get it done. And that includes, everything soup to nuts, from the direct lobbying plan and having our direct lobbyists go out and be in our state capitals, be in our national capital, and be talking about this issue consistently, and engaging, the caregivers that are delivering this care, whether they be a family member or an individual employed by an organization or an entity, and the entities themselves. And we found that kind of combination of people telling their stories at every point in the home care delivery process really builds a very, a very successful story and a very meaningful story to our legislators that really begins to move that needle. Last year alone, we advocated and we were successful in obtaining about $40 million in 6 different states, increasing home care reimbursement services. And this year we have another very daunting task ahead of us that we are well on our way to achieving. So that's a little bit about the organization. Right now, we're supporting about 8 different states, mostly on the East Coast. And of course, we have a national presence as well. And we work, again, with our legislators to get these reimbursement increases done. So we have a variety of employees that work in these specific states and are really experts in them. And that's because we found, when one Medicaid program, one Medicaid program. It is very different in every state that you're in. And you really have to know the nuances and understand, what goes on in order to really make a difference and get things across the finish line. And then, of course, we have a really strong grassroots team that really focuses in on training the people that want to tell their stories to do so, and what is going to be most effective, pulling out the nuggets of their stories that's really meaningful and impactful, and having, enhancing your ability to emphasize what that looks like, and providing opportunities and platforms for you to do that, whether that's recording a video on our platform or coming to us to an advocacy day. Or one of our most impactful and strong programs is we actually take legislators to people's homes to see what it looks like to have home care delivered. And some of the stories that you get from them, I remember we did one in North Carolina a couple of years ago, and a gentleman, explained that he was in very rural North Carolina and the power went off all the time. And the legislator kind of asked what this hunk of junk was outside on the porch. And he goes, "Oh, that's my generator." And it looked like it was held together with duct tape and spit. And he said, when the power goes out like it does all the time here, this is what keeps me alive. This doesn't keep ticking, neither do I. And the legislator was so astounded by that. He pulled out $600 right then and there, and gave it to them and said, go buy a new generator, because he didn't want them to be living like that. And that is really how we've created champions that, we had heard some of our staffers from before talk about running legislators that are willing to run through a brick wall. And that's what we do. We create legislators who are willing to run through a brick wall to get people the services that they need. And home care services are essential to ALS folks. We know that. We know that everyone would much rather be cared for at home than in institutions, and that's what we want to make sure that we're able to do. So this organization is run by grants, so it is free for individuals to join. And through that, you'll receive updates on what's going on in regards to home care access, both nationally and on the state levels in the states that we support, and invitations to join us to learn more, to perfect telling your story, to learn about interacting with legislators, learn how to host a legislator in your home, or learn how to work with your agency to bring a legislator to the office and they can talk about the whole care delivery model in conjunction with you. It's a really powerful partnership that we've begun to develop, and we're happy to be able to bring it to more people. So the website, if anybody's curious, is heartsforhomecare.com. We have a lot of information there, and you'll be able to register there as well, and learn all about what we have to do and what we have to offer.
Thank you, Laura.
Of course.
Least but not last.
I'll-
Not at all. He's
I very well will hold your judgment till I'm done.
He's going to knock it out of the park.
Apologies to those of you who are hoping to see my colleague Kathy Holt. I am here in her stead, but on behalf of my organization, I thank you for the opportunity to be here. My organization, my name is David Lipschutz. I'm also an associate director at the Center for Medicare Advocacy, which is a small but mighty national, nonpartisan, nonprofit organization dedicated to Medicare beneficiaries and increasing access to care. So when it comes to advocating for access to care and health care, it's often necessary to pass new law or change the language of existing law. Sometimes, though, there's language in the law that's pretty decent, but it's just not being followed or enforced. And when it comes to the Medicare home health benefit, that benefit falls squarely into the latter category. Now, certainly it can be improved, it can be expanded upon, but there is a growing disconnect between what is coverable under the law and what is actually available in practice. So I'm going to spend the next few minutes talking about what the Medicare home health law covers in theory, why that coverage is not being met in practice, and what we and others are trying to do about it. So starting up front, the Medicare home health benefit does not provide 24/7 care in the home. It's not designed to do that, but it is designed to provide a lot more care than is currently being accessed right now. So in order for Medicare to cover care in the home as part of its home health benefit, someone has to be homebound. That means they have a normal inability to leave the home without a device or some type of assistance, and it usually requires a considerable and taxing effort. That does not mean housebound or bedbound and that the person cannot leave home. We've seen a narrowing of that definition. A lot of people who meet the definition are being denied care because of an overly restrictive interpretation of being homebound. If you meet the homebound criteria, you also need to require intermittent medically necessary skilled care. That skilled care can be skilled nursing, it could be physical therapy, speech therapy, and occupational therapy, although occupational therapy can't be the triggering type of skilled service that you need. If you qualify for that and you need medically necessary skilled care, you also can access home health aides and other services such as medical social services. You can, under the law, have access to combined skilled services and home health aid services up to 28 and in very rare instances 35 hours per week, a standard which is never met today in practice, unfortunately. The care does have to be intermittent and cannot be daily. It has to be at least once every 60 days. But another thing that is widely misunderstood about the Medicare home health benefit is there is no duration of limitation. As long as you continue to qualify, you can qualify for Medicare home health indefinitely. There was a time, probably now 10, 15 years ago, where we were able to keep our clients with the minimal interventions from home health, the skilled care with home health aides in their home for years. And they would, without such care, would be in an institution of some kind. That is simply not available today. We've come to a point where the Medicare home health benefit is only really available for the short term for people who are going to get better quickly. It's for your hip replacements. It's for your knee replacements. It's for people who fall and need some intervention who are going to get better over time. Home health aides are virtually unavailable, despite the fact that the law says you can have a mix of skilled care and home health aides, up to the same ratio or even more. You can have a lot more home health aides and a little bit of skilled care as long as you have the skilled care trigger. And we've gotten to a situation where home health aides, as a percent of total services for home health, since 1997 has gone from 48%, almost half of all the home health benefit in 1997 was home health aides, to 2021 being 5%. We talk to people who try to deal with home health agencies and are told, we don't have any home health aides, despite rules requiring them to have so. Or we have one home health aide for 600 patients. Or if you're lucky, you'll get maybe an hour or 3 hours a week, and in a very derisive way be told, oh, we'll send our bath girl out. Or you can choose a bath, or you can have this other home health aid service in a way that does not make the benefit accessible in the way it was meant to. So how did we arrive here in this place where there's this disconnect between what the law says and what's actually available? In part, it's a widespread misunderstanding of the benefit, of what is available under the benefit, which is perpetuated not only by the home health agencies, but by the Medicare contractors that process the claims, the Medicare Advantage plans that oversee people's care in those enrolled in their plan. It is payment incentives. The law has not changed with respect to the overall Medicare coverage, but the payment incentives have, so that now home health agencies are incentivized to get people post-hospitalization rather than from the community, incentivized to treat people for shorter periods of time rather than longer because they get paid more up front, and are incentivized to gravitate towards people who will demonstrably get better over a short period of time. The deck is stacked against those who have chronic long-term conditions and might not necessarily get better over the short term. There are audits performed by Medicare contractors and the Office of Inspector General that misapply the law and perpetuate myths and things such as improvement standard that I'm happy to talk more about if we have time during the discussion. That creates a chilling effect on providers. So we're in a situation today where providers are incentivized to go after folks who are going to get better over the short term and to avoid people who have chronic and long-term conditions, even though such folks can benefit from medically necessary intervention, the skilled care and the home health aid services. So what are we and others trying to do about it? First, just trying to educate people about what is actually covered in the benefit. And when working with the regulator, the Centers for Medicare and Medicaid Services, they're good on some things, but not so good on others. They're good with a lot of pushing and prodding at making sure that the home health benefit in Medicare is accurately described about what's available. If you go and pick up your Medicare new booklet that every Medicare beneficiary is sent, it'll accurately say what the law is, but good luck trying to find a home health agency that will follow it. CMS has not been so good at overseeing their contractors that deny care inappropriately and perpetuate some of these myths. Looking at the totality of the problems, we tried to focus on one we're trying to address all the problems across the board, but we chose to try to litigate one issue, and that's diminished access to home health aides. So we brought a lawsuit that was intended to be a class action suit targeting the diminished access to home health aides and challenging a lot of things that are within the HHS purview, with things within the discretion of the Department of Health and Human Services, not seeking a change in the law, but a change in some of those payment incentives and greater enforcement of other things. Unfortunately, that suit was dismissed. We appealed it to the circuit court and are waiting for a response. Part of the problem is it's hard to prove when something doesn't happen. In the Medicare program, a home health agency can deny someone. We did a survey a few years ago. We put up a hypothetical patient that we were trying to find care for through home health agencies. And a lot of them, once they heard about the profile of the patient with long-term conditions, said, nope, sorry, we're not going to take it. Unfortunately, home health agencies do not have to take people, but they cannot discriminate against people. So one of the things we're looking at are some of these new rules that came out recently in Section 1557 of the Affordable Care Act, Section 504 of the Rehab Act, and trying to see whether or not we have a handle on trying to improve access to care for people based upon discrimination against individuals with disabilities. So it is an uphill battle, and it's getting worse. But this is absolutely an area where the law is actually decent, but it's just a matter of it not being followed. And with that note, that depressing note, I will stop and put myself forward as the least as far as the quality of the presentation. So thank you. Look forward to the discussion.
Thank you. Thank you, and thank you, everybody. We're going to get started with some Q&A. And I just want to get us started with a simple, concrete, sort of contained question. It seems that one of the points of intersection between what everybody was talking about when we're talking about accessibility of home care is the dearth of people in the workforce, right? We've mentioned that explicitly even. Aside from trying to attack the reimbursement angle, is there anything else that anybody thinks can be done to develop that workforce?
So in addition to reimbursement, one piece that we're also really passionate about and working on is data transparency. As I had mentioned before, when you see one Medicaid program, you've seen one Medicaid program. On the Medicare side, as many people complain about, but at least there's a universal data set where everybody's reporting in and you can kind of get access and show changes over time, such as a reduction of home health aides being authorized or being utilized. On the Medicaid side, unless your state is doing that individually, there's nothing. And even if there is something, because there's so many different waivers and different waivers can be applied differently in different states, it's still not an apples to apples comparison. So that's a huge issue from state to state. So that we're working on is to get at least what their state's data is and out there, and look at what utilization is. You look at quality of care, look at missed shifts, so we can begin to see where is the problem and how we can attack it on that side. So that's another big piece, I would say, aside from kind of the reimbursement piece. And the other piece nationally that I think you have to look at on the home care side, when CMS when Medicare and the Medicare and the Medicaid programs were created decades ago, home care did not exist in the way that does today. The medical advances that have happened have been tremendous. So you can do so much more in the home with quality. The problem is that regulation and that existing program as it started doesn't show that. And there's this institutional bias. So we're working to overcome that and to kind of flip that on its head, because we know it's more cost effective. We know it's, patient preferred and where people want to be. But the rules still don't necessarily support that. And it's a lot easier to get into a nursing home and to have that, it's actually an entitlement on that side, state level wise. You're entitled if you are medically and clinically, and financially eligible to get nursing home services. That's not often the case in our states. And that in and of itself is, a tremendous problem that we're trying to tackle.
Thank you. Questions? Yeah.
Can anyone address the inequity that exists for people who choose to be full-time homemakers and then are ineligible for Medicare and SSDI benefits?
Yeah. Well, there are rules when it comes to at least Social Security retirement that you can be eligible for such benefits based upon your spouse's work history. And I think in order for that to happen, you have to have been married, I think 10 years perhaps. And then it's possible to qualify based upon your spouse's work history. It's patently unfair, right? Because who's to say someone who comes to an office like this works any harder than someone who's maintaining a household and taking care of a family? So there's that one measure, that the eligibility for Medicare for folks under 65 based upon the receipt of Social Security disability insurance, SSDI, that 2-year wait is just patently unfair. I mean, that was created as a cost-saving measure by Congress, pure and simple. It has no excuse to continue. And that doesn't directly answer the question, but I know for Social Security retirement benefits, it is possible to, if you are able to, if you do have a spouse, been married for a requisite period of time, even a former spouse, to qualify for the Social Security retirement that can then trigger eligibility for Medicare.
Hi, my name is Candace. I have a question. I'm very active, but I am catheterized, and sometimes I have problems with my catheter at 2 o'clock in the morning. And because I'm able to get out of my house, I can't get nursing skill. But if I have to go to the hospital, it's 6 hours just to get a catheter change. And if I choose not to, I end up with losing layers of skin from burning of urination, which ended up in the hospital anyway for 6 weeks. How can that help? How can I get some help in that way? Because unfortunately, I still do drive, but 2 o'clock in the morning, I have to wake up my home health aide or a child to get out of bed by a Hoyer, to get in my chair, to go to the hospital, which right then and there would be just enough time for an on-call nurse to come and change a catheter for me. Is there a way that there is some kind of help there for that matter?
Well, I'm going to start by not directly answering your question, but responding to something that you said. Just because if talking about Medicare rules, just because you can leave the house, just because you can drive, does not mean that you're not homebound. That, if you were denied for that reason alone, I believe that's likely improper. They need to look beyond that.
I would say if you were denied because of that, first and foremost, in your state, many states have a either like a legal aid or a health legal aid that takes on cases for free. And, that appealing that decision, I think, is certainly something I would recommend pursuing and looking at. I'm not sure if your state has one or not, but many do. And that's been a tremendous help to a lot of home care clients that we've encountered. I would, do a Google search because I'm not sure which state you're in and what either, I'm sorry, New Jersey. There is, I think it's Community Health Law Project is the name of the one in New Jersey, because I do know that one. But, that doesn't sound right.
Yeah, and on our website, Medicare-Advocacy.org, we have a lot of materials that talk about Medicare coverage rules, including home health and including what the homebound rules are. So at this point, there's nothing really to appeal. You can go tomorrow to another home health agency, and as long as you need some type of skilled care intermittently, as long as you can show them that you're homebound, in theory, you do need a plan of care from a clinician, usually a physician. But I would be prepared to argue to them, look, I meet these homebound criteria. Because I can leave home doesn't mean that I am not homebound. You have to say if it is the case, it takes a considerable and taxing effort. You need assistance to do so, and that it's not all the time, every day. But I wouldn't I would look at it further, in other words. Yeah. Mm-hmm. No, not at all. Yeah.
Could I ask a question? Oops.
There's a bunch of hands up, so I don't, in which order?
Okay, we only have time for one more question. So I don't know. I guess.
Yeah.
I'm sorry to hog so much question time, but I appreciate it. First is just a comment about the 10 years being married. You look at same-sex couples, they haven't even been allowed to be married for 10 years. So there's an inequity right there. But I was wondering about in Maine, there's now, you can get paid for home health care, or, whatever the right words are, for a spouse or a parent of minor children. But, it seems like there's also, if I was looking for care for myself, I might look to my sister who lives locally and see if she would be able to do that, or a niece or a nephew, or people with children, or adults of adult children who have ALS or other issues. So I'm curious about any paths for that to happen. And then more generally, all of these things are increasing government spending, and there's a huge industry of people whose sole purpose is to reduce government spending. And that seems to be reducing our ability to access adequate care. So any thoughts on that?
My understanding is
Yes, across the board. All of that. But with respect, just talking about Medicare, I think you probably have a lot more to say about it. But as far as people who can provide direct assistance, like essentially home health aid services, and whether or not family members and others are available to do that. Right now through Medicare, it's not set up to do that because all covered home health is done through a home health agency. So it has to be an employee of the home health agency. That's something to look at as far as what we can change. But now we have situations you're talking about costing, the program more. A lot of times people will go to a home health agency. They will need skilled care, but they'll also need some home health aid services. And an agency will tell them, okay, we'll give you the skilled care. We don't have home health aides, but if you'll pay for our, services over here, you can hire some home health aides that'll provide the services, which, of course is inappropriate. And as far as the federal government, costing them more money, a lot of it is the way that legislation is scored. Mm-hmm. The Congressional Budget Office, which is kind of like the umpire on how much legislation is going to cost or save, doesn't factor in all the things that we might think that would be factored in, like, oh, wait a minute, if I get care in the home, that's going to save money for a nursing facility. They won't really factor that in. Mm-hmm. So a lot of it is the way that legislation is viewed.
What we were finding in Maine, though, is that people were qualifying for care that they weren't receiving because they qualified for so many hours and the home health care agency couldn't fill those hours. So, making it so that Linda, could go ahead and provide that care actually gave, John a continuum of care. Do you know what I mean? That he qualified for, that he wasn't receiving in the first place. So in terms of it costing any more money, I mean, I guess that would cost more money, technically, but it's something he already qualified for. It was something that they already figured they were going to have to pay out on if conditions were ideal and there were enough home health care workers out there to help.
And just to add to that, it was the only person that was disqualified from being on his paid home care team was the spouse. If it was his sister or his brother or his child or his mother, any of them, a friend, any person on the street could be paid. It was specifically targeting the spouse or the parent. And, if it was a child, a case of a minor, it was the parent of a minor child. So this gentleman saying that, his spouse, they could still be paid. Anybody, as long as it wasn't the spouse.
Yeah,
So
sorry.
Go ahead.
So it's a CMS regulation that's applied on the Medicaid side that if you're receiving personal care services, the spouse typically is not able to be a paid caregiver. However, aunt, sister, whatever, or a power of attorney, right? If that individual is legally over your care and finances. On the home health side, if you are getting Medicaid home health services, like in the case of a child, the parent can still be a paid caregiver in that case. And that looks differently in different states. In some states, they have two programs where the individual can hire that person directly, and then the state pays them through, I think we mentioned, like a financial intermediary or a fiscal intermediary. And then you also have kind of an agency that can employ or hire that individual to provide, training and education and oversight, and be able to assist in the delivery of care and still have that individual be a paid family caregiver, if they're especially on the personal care side. So there's kind of two ways to tackle it, depending on what state you're in, what programs you have, whether it's part of the state plan and home health aid services or part of a waiver and personal care services.
Thank you. And with that, I think we're going to wrap up. So I want to again thank all of our panelists from Maine, from DC, from everywhere, and our audience. Thank you very, very much.